Welcome to Dr. Cheryl's Pod Couch, where we talk about all things mental health. Today, I am so excited to have Dr. Amy Sullivan here. She is a licensed clinical psychologist at the University of Colorado Depression Center. She provides evidence-based psychotherapy to youth and adults with mood and anxiety symptoms, with a special emphasis on treating bipolar disorder. And that's what we're going to focus on today. She has earned her doctorate in clinical psychology at CU Boulder, and she completed her pre-doctoral clinical training at UCLA with Dr. Miklowitz. Did I say that right?
Exactly.
And so that's important because he is the creator of family-focused treatment for adolescents and adults with bipolar disorder. And that's what I'm excited to talk to you guys about today. I've been through a little bit of this training, and I was so impressed with the training and the efficacy that you talked about. And I know that so many people have a loved one with bipolar disorder. So I am really excited to just dive in. So the first thing I'm going to ask you is you have dedicated the last several years of your career specifically to this treatment model, FFT. And it's family-based. So tell us why this model and all about it. How many other universities are using it? And are there any other cities beyond Denver that are using it as well?
Sure. So first off, thank you so much for having me here. I'm so thrilled to be here. This particular protocol, family-focused therapy, or FFT, I was first introduced to it in graduate school. That was the lab that I was in. We completed some of the randomized control trials to test the efficacy of the protocol. And just to give a little bit of an overview, the treatment it's a psychoeducational focus where there's 3 modules. You go through the first set of meetings with the family. You're really trying to talk through the symptoms of bipolar disorder. What is bipolar disorder? What isn't bipolar disorder? What are the factors, the risk and protective factors that can have an influence on symptoms? And how, as a family, can we really work to limit the risk of future relapse? And after we have a chance to develop that relapse prevention plan, then we move on to communication skills, instruction, and then some problem-solving skills. So the overall aim of this protocol is to reduce family tension, reduce levels of hostility and parental over-involvement or family over-involvement with the patient, because there's just tons of research to suggest that that's the best environment for bipolar patients to do as well as they can.
Okay, so I know that I just jumped right into FFT and I can do that because I can get excited. But for anybody listening, there might be people listening who say, yes, I have a loved one or myself that have been diagnosed with bipolar disorder. And there might be a lot of people that are just wondering. So can you talk about what are the signs and symptoms?
Absolutely.
And kind of start there, and then we'll dive more into the model.
Perfect. So sure. So bipolar disorder, bipolar is one of those terms that's kind of like OCD or kind of like ADHD, where it gets tossed around really in such loose ways, or it's such a colloquial usage. And so, technically bipolar disorder is diagnosed when people experience 2 kinds of mood episodes. Those mood episodes are periods of depression and periods of either mania or hypomania. And those elevated periods of hypomania or mania, they can be really pleasant experiences that people can feel really confident, really giddy, really cheerful, really high energy. Or they can be really irritable periods where there's just a lot of agitation and they're not particularly pleasant. But for bipolar disorder, you have to have, or you typically have the combination of both of those experiences. And there's all sorts of sort of the definition includes all sorts of specifications about how long somebody needs to experience these symptoms, the combination of symptoms that are required to meet diagnostic criteria. But overall, we're looking for a combination of those depressed symptoms alternating with periods of elevated symptoms.
And so how many people do you think in our country are affected by bipolar disorder?
So in the US, it's about 3% of the population that has bipolar disorder, which translates into between 9 and 10 million individuals.
That's a lot.
It's a lot of people.
Wow. So of those that you just said, those 9 to 10 million Americans, how many of those are children?
So that's a great question. So the that study or that study was looking at adult patients with bipolar disorder. So that's that same percentage of teenagers and kids under 18. It's about 2 to 3% have a bipolar diagnosis as well. Although the exact numbers for that are still the research is still being completed to sort that out, just because it's been more recently accepted that children and teenagers can have a diagnosis of bipolar disorder. It wasn't all that long ago, excuse me, that it was actually pretty controversial for somebody to suggest that a teenager or especially a child could have bipolar disorder.
Really? That surprises me. I was in the first part of my career in residential treatment, and we had plenty of kids who had a bipolar diagnosis.
Right.
But yes, it probably was rare, and they were probably in residential treatment because of it, not living at home. So if I'm a parent and I'm listening to this, because I hear this a lot, even when it comes to young children, parents will say, I don't know. I mean, one day they're happy and the next day they're angry.
Right.
Could they be bipolar? So for you, what are the ways that you kind of go, I understand kids, they're developing and they can be moody. Here's the difference between a moody, unpredictable, roller coaster type of emotional kind of kid versus somebody who you may really look to see what the signs of bipolar are.
That is such an important question. And it's something that comes up certainly in clinically for me a lot as well. This question of, a lot of times parents will phrase it as, does my child have a diagnosis of teenagerdom, or is this potentially a mood disorder? And I think that it's important to look at that and answering the question in a number of different ways. First, we want to look at the intensity of the kinds of things that the teenager or the child is experiencing. So a certain amount of sleep dysregulation is really normal in youth. There's just a lot of sleeping in on the weekends, trouble sleeping. That's pretty typical. But if there's consistent difficulties with sleep that interfere with the child's ability to function at school, to do things that they want with parents or friends, or especially if there's a decreased need for sleep, where there's a true lack of desire to get more sleep, not a child who only sleeps 5 hours and they're tossing and turning all night trying to sleep, but a child who only sleeps 5 hours at night because, who has time for sleep? I've got stuff to do. Those are the kinds of things that we pay attention to because of the intensity, that it's above and beyond what we'd expect in normal development.
Yeah, let me say something about that, because when I did the training with you, that was probably my greatest takeaway, to be honest, was just that one piece. So now I always look for sleep disturbance, right? Are you sleeping too much? I'm looking for depression. Are you sleeping too little? And so regardless of what they answer, I now say, is that the amount of sleep that you want to be getting?
Right.
Where I never really used to say that. Maybe I said something else, but now I just blatantly say. And so I think that's just a good tip that a parent can take too. If your kid is over or under sleeping, ask them.
Right. How much does it match up with what they're hoping for?
Right.
Because that can be so important. There's so few clear indicators for psychiatric diagnoses. We don't have the benefit like medical professionals do of saying, oh, your temperature's 101. That means automatically you've got a fever. Right. We have to look for all these behavioral indicators that are so fuzzy. They can be, but that decreased need for sleep, that experience of I hardly slept and who cares? That's a really concrete, clear sign that something's off, and it's likely an elevated mood.
I would add too that if there's someone listening to this and they have a child who they're worried about their moods, one of the things that I look for too is their risk taking.
Absolutely.
Right. And so, and then again, you can say, well, don't most teenagers take risks? But you describe it maybe. What would be the difference between an average teenager taking a risk and maybe a child who may have a mood disorder or bipolar disorder doing high risk behaviors?
So that's a really great question. It's another area where there's a lot of, it's fuzzy, right? There's no clear quantitative concrete distinction. So the best way I can describe it is through examples. A typical teenager pushing the boundaries might stay out past curfew, might experiment with substances like marijuana or alcohol, but they're going to be responding appropriately to consequences. If they're grounded, if they have natural consequences, then there's going to be you're likely to see a decrease in that risk-taking behavior. For kids that have mood problems, a lot of times there's not that response to consequences that can shift their behavior. And oftentimes the intensity of that risk-taking is really out of character. It's not just, I'm going to stay out an hour past curfew. It's that I'm going to leave and I'm not going to come home for 2 or 3 days. One of my favorite examples from a family that we had in one of these studies came in maybe about a couple weeks after this teenager had a potential manic episode. And one of the cues that the mom mentioned was that he was being particularly risky, and he was he rode BMX bikes, and he was into that scene. But when she drove home when he was in this elevated state, he had set up a bike park basically in his house while she had been away, and he had ramps going up to this first level of the house. He had been biking on the roof at one point. Just extraordinarily risky behaviors that were out of character even for somebody who's really familiar with BMX bikes. So the intensity of these risky behaviors is noteworthy, more likely to be noteworthy if it's part of a mood diagnosis.
So if somebody has a kid, that is like a wow of a story, right?
Right.
So someone has a kid like that. My experience is that the first thing they're going to do is they're going to go to their pediatrician. Do you feel like today pediatricians are equipped to know these kinds of signs and make the appropriate referrals?
That is, it's a great question. I think that it is certainly improving now with increased awareness of bipolar disorder in kids and youth. And I also think that it's one of those areas where pediatricians vary in terms of their familiarity with exactly what we're talking about, that difference between the typical aspects of teenage development and these really specific ways that can vary into mood diagnoses. And so I guess what that requires, that ability to say, yes, this is a mood diagnosis, is not only this shift in intensity, but we're also looking for a clustering of things happening together. If somebody's if someone's doing well, but they have these experiences in isolation, like risk-taking behavior or sleep dysregulation, that's not as likely to be a mood diagnosis as it would be if they had mood shifts, if they had sleep dysregulation, if they had appetite dysregulation and risk-taking behavior that were all happening together, all shifting together. And that a lot of times that complexity for there's a lot of complexity in the assessment. There's a lot of complexity in trying to differentiate between normal teenage behavior and bipolar disorder. That's where it really suggests that a referral makes sense in those cases, rather than a pediatrician trying to digest all of that and handle all of that in one of the well checks.
Right. I think that, and that's why all of us need to be our kids' advocate, right? Because if your gut says, and like you're saying, there's very good pediatricians and they're very good at what they do, but now pediatricians have this demand on them that they know mental health as well.
Right.
And that's not what they're trained in.
Right.
So I feel like, having conversations like this, if there's a parent listening and your pediatrician says, sounds like, they're being a teenager or, maybe you should go see somebody. It's more than that. This is really, even for you who does this for a living, it's still a complicated, complex process and important to get it right.
And I think that's a really good point for parents to go with their gut. If it's the more information you can have about what's going on with your child's mood, with your child's dysregulation in sleep, or difficulty with going to school, or difficulty with functioning at school or with friends, sorting that out as early as possible is so important It's so important for how the family's doing. It's so important for how your child's doing. So I think really trusting your gut and asking for those referrals, even if a pediatrician doesn't automatically offer them, I think that's a really important step.
Yeah. So going back to the family piece again, what's it like to go through the program that you do for the rest of the family members who don't have the diagnosis and maybe feel like, well, why do I have to be here? I'm not the one that has the bipolar disorder. My brother does, or my dad does. And so that's my part A question. And part B, because I just used the brother-father example, is it more prevalent in males than in females?
Oh, great question. So I'll start with that one. For bipolar 1, which is the more intense version of bipolar disorder, that means somebody has mania. It's actually an even split between males and females. Is that it's you're just as likely to be male or female to have a bipolar 1 diagnosis. With bipolar 2, it's less common in males.
Gotcha. And so going back to the original bigger question. So you are, you're sitting there as a family member. What is that like, and what kind of feedback are you getting from siblings or spouses around going through this process?
So it's a really common circumstance where there's, we'll say, a range or a variety of levels of motivation across family members to be willing to go to therapy in the first place or to remain engaged throughout the process, especially if we have only one person in the family that's what we call the identified patient, or the person who has the diagnosis. That there's one of the initial steps in this family-focused therapy protocol is to really work with the family to identify the goals of why what they want to be working towards, to really tap into their motivation for why they'd be wanting to come in for family therapy. And often that's a great chance to work with individuals on exactly what you're talking about. If somebody's having difficulty with identifying goals, or they say, I don't, a lot of times when I work with kids and teenagers too, a lot of times they're like, I don't even want to be here. This is, I'm not into therapy. Trying to get a sense of something that could improve if it's something that they would be interested in seeing improve by staying in family therapy can be an important part of keeping them engaged, even if they don't have symptoms themselves to work on. So I guess, if you stay in treatment, it will get your parents off your back. Will they stop pestering you about learning these kinds of skills? Okay, if that's part of it, let's just focus on that. How can we do this treatment well enough to keep, to help you feel more independent at home, or to keep your parents from bothering you in these areas?
Yeah, that's a good way to put it to a teenager.
Yeah.
So what are the other cities or universities that are utilizing this family-focused treatment model?
So it's something that's really remained within the academic community in terms of of access to this particular treatment, meaning that a lot of the therapy has occurred in the context of these randomized controlled trials or pilot studies for the protocol. And so right now, so Dr. Miklowitz has a lab out at UCLA. And so they've been working on disseminating its use into the community mental health programs out there and increasing its access, clinician access in the community out in LA. And but aside from that localized availability, there hasn't been much by way of trainings in this protocol or workshops. Just given that focus on the academic assessment of the protocol. And so one of the things that I've been really trying to work on over the last couple of years is increase clinician access to the protocol, because we have so much data through those studies to suggest that it works really well. It works well to decrease the intensity of depressive symptoms, to reduce the risk of relapse, to improve the quality of life for individuals with bipolar disorder. And it compares really well to other protocols that are widely available, like cognitive behavioral therapy or interpersonal and social rhythm therapy.
So it works just as well, or does it work even better according to the studies that you have?
So that's a great question. So if I put my researcher hat on, get as specific as I can here, that this is for the studies that have looked at adult patients with bipolar disorder. In the comparisons with CBT or IPSRT, there were a number of outcome variables where they performed equally well. And then there was one, and now of course, I think there was one, maybe two variables where FFT performed was superior to CBT and IPSRT.
I mean, that's amazing. I feel after I was trained on this and heard you talk about it, and I am a total systems oriented clinician. I can think of nothing better than getting the whole family engaged. I also see that there'd be probably some obstacles with that, but also maybe the upside of getting the identified patient to therapy every week.
Right.
Because that can, I think medication compliance is one of the biggest hurdles, correct, in treatment. And so I am really curious, how do you deal with it though, from that family perspective, when someone is just overtly resistive, like this isn't my problem and I need to go home and do homework or go to the mall with my friends.
Right. So I have had one patient once, a 12-year-old boy who asked for a therapist for Christmas. And everybody else that I've met with, child or teenager, has had some degree of, I don't want to be here. This isn't going to work. My parents made me be here. There's that resistance that you come up against. And so there's, I think one of the first steps in addressing resistance, which can be even greater in the context of family therapy, is to sort out where that resistance is coming from. You know, is this person really reluctant to engage because they've done therapy in the past and it's gone really poorly? Is it that it's a family where it's really uncomfortable to talk about emotions? Are they concerned about the fact that they aren't sure if this is going to work, and so it's easier just to retreat rather than risk the treatment failing? Are they just bored? You know, maybe they're just not into what's going on. But if I have a sense, if I can spend some one-on-one time with the person, or even a series of people in the family that are being resistant, then I can try to find some common ground. You know, if treatment is boring, thank you so much for telling me. Let's see what we can do. My challenge over the upcoming 3 sessions is to do whatever I can do to make these meetings a little bit more interesting for you, or more applicable to the changes that you'd like to see at home. Will you give me a shot? Let's do an experiment for the next 3 weeks, and you tell me. I'll check in and see how you think I'm doing. And so
that's great languaging. And maybe even, like, I was thinking for how difficult it might be for kids who a parent is the one with the bipolar, but, you know, just having that languaging, because I think whether we're talking about bipolar disorder or anything else, there's a lot of times resistance to treatment.
Absolutely.
So where can people get trained? And do you travel and train people in other cities? Though somebody's listening to this and says, gosh, this sounds great. Is there an option for other people?
The short version is I'm working on that program right now. Is that right now I've been really fortunate to receive funding through the Caring for Colorado Foundation and through support of the C. Johnson Depression Center to develop a training program that's focused on increasing clinician access to FFT in Colorado. And what my hope is to expand the program so that it's available in different states to clinicians who, right now, they have access to the manual. There's a published manual for the treatment, but there's not workshops across the country. And what I'd really like to try to do is continue developing this program so that we can change that, because it's something where, in addition to the data that really suggests this is something that can be very helpful for patients, I just personally really like using the protocol. You know, these families can be really, they can be experiencing a lot of stress. They can feel really chaotic, and having this really structured framework to help families reduce that stress and see the kinds of support that they can provide for their family members with bipolar disorder, it's really rewarding. And it's something that I think the protocol is really, it's concrete, it's skills focused, it's very flexible, but and adaptable to a family's needs. And so I think it's the kind of thing that clinicians can make quick use of in their practices. And so what I'm trying to do is improve access to care to bipolar patients through increasing access to this protocol for clinicians. And my hope is to continue doing that in the future. And the best way to access it would be through the website for the Depression Center. So that's coloradodepressioncenter.com. And there's a subsection of community resources and programs. And there's a tab for the Family Focused Therapy program.
I think that's so great. I think if someone's listening that's in Colorado or outside of Colorado, I feel like this is the time right now where mental health is on the minds of many, many people. And hopefully people can seek it out, seek out the resources. I've been through part of the training and it's phenomenal and has just enhanced my work. So I hope that more people will be able to get access to this. And I thank you for the good work and the good research that you and your colleagues are doing.
Thank you so much.
Thanks for being on.
Thank you for having me.
Bye-bye.